Hello, my name is Bagnall. I'm an Interventional Cardiologist at the Freeman Hospital in Newcastle upon Tyne. Today we're going to be doing a challenging primary PCI case. Our patient is a 74-year-old female who developed acute onset of chest pain at around 7 a.m. this morning. She made a call to the emergency services at around 8 o'clock and the ambulance arrived at 8:15. There they found that she had a history of angina going back over a year and a half, and that she was scheduled for a hip operation in 2 months' time. They took the following ECG, which, as you can see, shows a left bundle branch block pattern. They diagnosed an acute anterior STEMI and gave her 300 milligrams of aspirin, some oxygen and some morphine for pain relief, and she was transferred immediately to our catheter lab. She arrived here at just past 9 o'clock, and we've done some of the initial setup already. So in place we have an intra-aortic balloon pump that was inserted via the right femoral artery, and that's helped to augment her pressures, and her aortic pressures are now 90/45, but she remains tachycardic with a heart rate of 110. We've taken pictures of the non-culprit artery on the right, which was free of significant coronary disease, and we've approached this from the right radial artery. Generally I prefer to do my cases via the right radial artery because of reduction in bleeding. In this case, where we have to have femoral access anyway, for the balloon pump it probably doesn't make too much difference. We've now selected an extra backup 4-guide catheter, and we're going to take some pictures of the left system to diagnose what's going on. I should add that in addition to the aspirin, she's also been given some heparin at 70 units per kilo, and she's been given ticagrelor at a loading dose of 180 milligrams. But for this patient, alternatives might include clopidogrel at a dose of 600 milligrams, and she's just below the age cutoff for prasugrel at a dose of 60 milligrams. So let's see what the pictures of left side show. Okay, so our patient has now arrived in the cath lab. The ambulance crew, as we heard, had given 300 milligrams of aspirin in the ambulance. We have given 60 milligrams of prasugrel as a loading dose for additional antiplatelet therapy, but the choices are there between 600 milligrams of clopidogrel or 180 milligrams of ticagrelor could also be used. And we've taken a radial approach here. I generally try to do all my primary PCI cases via the radial approach whenever possible, simply because there seems to be a lower risk of bleeding by using the radial route, but using the femoral route is fine. It just depends on what your particular skill sets are. We've taken some setup shots here. Again, different institutions will have different policies about whether they take non-culprit angiogram first. So in this case, with it being an inferior STEMI, we would suspect that it's the right coronary artery that's involved. So the non-culprit, we've taken a picture of the left side. Our left-sided pictures are very interesting because what we can see is that the RPLV branch of the right coronary artery and the distal right coronary artery fill from the left system. And this is typically a scenario that you might encounter if somebody had a chronic total occlusion of the right coronary artery. Now this can lead to some difficulties in working out what's going on. So for example, in this case we also see that there is a severe narrowing in the mid-LAD. Now if the LAD was the source of the major collateral supply to the right coronary artery, it could be that the acute lesion is in the LAD, but the inferior wall has become ischemic because that's where it was drawing its blood supply from. However, in this case, the major collateral branch to the distal RCA comes from a branch of the circumflex. So although there's RCA LAD narrowing, I don't think that's the culprit lesion, but it may still be that we're dealing with a significant lesion in the right coronary artery that has become acutely occlusive. So what we'll do now is cross over to our pictures of the right coronary artery. I've selected a Judkins right 4, And our first picture we see here is in the LEO projection. And we've got an occlusion with TIMI zero flow beyond the mid-RCA, just after the origin of the first RV marginal branch. We've taken an REO shot as well, and again we see the same. When I'm taking angiograms during primary PCI, I tend to leave my foot on the pedal longer, because you do occasionally see some slow filling of the distal vessel, which can be very helpful in determining guide wire position. So what I'm going to do now is to take my standard 014 guide wire. Typically I'll be using a spring coiled guide wire. If you use ones that have polymer jackets, there's a higher risk of picking up small side branches with that, and because of the drop in tactile feel that you have with polymer jacketed wires, that can be sometimes difficult to detect. Okay, so we're going to bring our guide wire down now. I've taken a standard spring coiled guide wire, generally a workhorse wire. I avoid using polymer jacketed wires generally because of the reduction in feel that you have with those. It's quite easy to pick up small branches and not be aware of it, but you want to, my guide catheter just diving in a little bit there. I'm just going to pull that back a sec. That's better. You can see that you can have quite dynamic changes in the heart tracing as we're doing this, because we saw he was the patient that had a little bit of heart block before they arrived. It now looks like that's got better. So coming up to the lesion itself, you can see it just bouncing off that a little bit. You just want to give the guide wire some movement and gently feel your way through, if possible. Get some movement on the wire. I'm just going to take my talker onto here and just give myself a bit more ability to torque these stiffer wires that we have to use in the simulators. Okay, so I'm giving a little bit of movement to my guide wire. Okay, and you just saw it slip past the lesion there. So you need to have a sort of mental roadmap of where you're going with this, and to use feel to a great extent. Be aware that you might need to use different projections. Again, you can see that our patient's become a bit tachycardic. It looks like we're picking up a PDA branch there and PLV branch there, so I'm pretty happy with where my wire is. When you get the wire across and you begin to get some reperfusion, it's not uncommon for the patient to have some dysrhythmias. You can see there we've gone from a sort of junctional rhythm back now into sinus tachycardia. Blood pressure's better now that they've got some atrial kick again. But now we've got our wire across, we're going to take another angiogram. Again, a nice long run to see whether your wire's in the right place. If you've got some distal filling, we've just got a little bit of distal filling there, but not much beyond that. I forgot to mention earlier on about the other types of anticoagulants that we're going to be using here. In this case, we've selected some bivalirudin for the patient, and we're using that in combination, as I said, with some aspirin and some prasugrel. So we've got a high thrombus burden there, poor flow. So what I'm going to do is perform aspiration. The aim of aspiration is trying to bring out as much of that clot out of the vessel as possible to reduce your chances of distal embolization and no reflow. So there are a variety of different aspiration catheters available in the market. They're all very similar in design. They're a hollow plastic tube to which you attach a three-way tap and a syringe which can be held on negative pressure. And when you open up the three-way tap, that negative pressure is applied to the coronary bed and it sucks back blood and hopefully clot from the artery. So if you could just fix that there for me, thank you. So I have the wire now. So I'm advancing my aspiration catheter. These are all rapid exchange devices. Wow, I've got some deep engagement with my guide catheter, just bringing that back there. You can see the aspiration catheter coming down. And when I bring it into the artery, I ask my colleague to open up the three-way tap and to start aspiration. So we've started our our aspiration now, and I slowly advance the aspiration catheter. If it'll go through the lesion, that's great, but you don't need to go a long way beyond the lesion. If you do that, you've got a bit of a higher chance of causing some distal embolization. And then you slowly bring it back, aspirating all the time, perhaps giving a little bit of rotation to the aspiration catheter as you do, just to change the orientation of the end hole. And what's very important is that as you bring it back out of the guide catheter, that you keep that negative pressure all the way until you've got the device out. The reason for doing that is because you can have some clot that gets stuck at the end of the catheter, and what you don't want to do is to release the negative suction and to drop that clot into the catheter and then inject it during the next angiogram. It's often the details that make the difference in cases, so what I like to do is to bleed back my system at this point, or to aspirate from the sidearm, just to completely ensure that I haven't got any clot in there. And the other reason for doing that is that when the aspiration catheter comes out, it can often entrain quite a bit of air into the system, and you want to make sure there's no air when you do that. So we've got our aspiration device out. My guide catheter keeps wanting to deeply engage itself, so I'm just going to back it off and make sure they've got a much more normal looking aortic pressure trace before making any injections. And we're going to take another angiogram now and see whether we have flow. So we've got flow down into the distal vessel. We can see our wire is in the correct place. The interesting thing that's happened here is that we have a little bit of proximal spasm, and I suspect that relates to the way my guide catheter was deep-seating itself. So we're going to give a little bit of nitro. The blood pressure is a little bit low at the moment, so I'm just going to give a small dose of intracoronary nitroglycerin. Just going to give 150 mics here, 150, 200 is about normal. So we're going to administer that. And once that's in, we're going to take a picture again and see what the state of the coronary is like. So our spasm's better, and you can see our pressure's better. And now that we've got this artery open, we can see lots of that backflow now into the left coronary system. So I think what that tells us is that this was probably a highly stenosed artery beforehand, but it wasn't a chronic total occlusion because it was pretty easy for the wire to pass through with just standard guide wires. What I like to do now is to give a couple more boluses of intracoronary nitrate. I often can give up to a milligram of nitrate. The reason for that is to make sure that the vessel is maximally dilated. Patients will often arrive in the cath lab with a lot of adrenergic stimulation from the pain that they've been in, and that can cause a lot of coronary constriction. And that can make the coronaries look small and increases the risk of you putting in too small a stent for the vessel size. And that can lead to long-term problems with late stent thrombosis or restenosis if you've got an undersized stent in the artery. So I give repeated boluses and then take a picture when I hope that the artery is back to looking like its normal size. So we take an angiogram now. And we can see this is a pretty sizable artery. When we're judging this, I'm looking at visual clues from the size of my guide catheter. I think this is at least a 4.0 vessel. So the next question we face is, do we direct stent or do we predilate this lesion? The risks of predilatation are that you will inevitably cause more embolization of thrombus from the lesion site, and that can increase our chances of no reflow. The benefits of predilatation are that you know that you've got the lesion adequately prepared and that you're not going to be faced with a stent which can't be adequately expanded. This is a young guy though. We've not seen any significant calcification of the lesion, so I'm pretty happy to do a direct stent here. So I'm going to select a stent. I've had a discussion with the patient beforehand about whether he's able to comply with at least a year's worth of dual antiplatelet therapy, particularly questioning them directly about whether they have any upcoming surgery or other medical interventions that might need them to interrupt that. He didn't have any of those, so I'm going to go ahead and use a drug-eluting stent because that's going to minimize my risk of the need for target vessel revascularization in the future. with the newer generations of drug-eluting stents, trials don't seem to show any heightened risk of late stent thrombosis compared to using bare metal stents. So I'm going to select a 4 by 12 millimeter drug-eluting stent, and I'll just get that lined up here. What's gratifying about primary PCI cases is that usually by this stage of the procedure, once the artery is open, the patient is feeling 100% better, the rhythm is stabilized, and all is looking rosy in the garden again. And it's a very gratifying procedure for that reason. The patients feel an immediate benefit. So we're going to bring in our stent here. You can see it's just appeared now just by the end of the guide catheter. I'm advancing it across the lesion. It's crossed that very easily. I'm going to check our stent position, which looks fine. And we're going to deploy this stent now. And when we're thinking about pressures to use for stent deployment, really just stick to nominal pressures if you can. High pressures, again, increase your risk of no reflow. You can see we're having to go up a little bit high. That looks like it's well expanded now. That's at 14 atmospheres. Just draw one of those. And I typically leave these up for about 30 seconds to make sure it's fully expanded. I won't do that this time around just because this is a videoed case. We're down with our balloon now. I'm withdrawing the stent balloon now into the guide catheter. I'll usually take a little shot here before completely taking the balloon out of the system, because if you have the kind of catastrophic scenario where you've perforated the artery, you've immediately still got a balloon in place on the wire that you can bring down quickly to tamponade the vessel. So, performing our angiogram after our stent deployment, and this is always the disappointing thing that you see sometimes, that we have a no reflow phenomenon here. I'm leaving my foot on the pedal just to demonstrate that the flow of contrast into the artery is slow, and the way that the contrast leaves the artery is also delayed as well. And that's a typical pattern that you see with microvascular obstruction due to no reflow. You'll get this in cases where you have a high thrombus burden, particularly if you've not performed aspiration or aspiration has been unsuccessful. If you've had to do a lot of balloon dilatation at the lesion to be able to deliver devices, or if you've had to do post-dilatation, all of those things increase your chances of no reflow. So what do we do to get the microvascular flow improved? Well, at this stage it's mostly pharmacology that you're reliant upon. There are a number of different drugs that you can use. I'm going to use some adenosine here, and you can deliver that either through the guide catheter, or you can deliver it down into the distal vasculature simply by reintroducing your aspiration catheter and using the three-way tap to deliver that in, and that can reduce your systemic hypotension that can be associated with some of the drugs. So we're going to use adenosine here, but verapamil, sodium nitroprusside can all be used. All have their pros and cons. And again, you may need to give more than one bolus dose here. I've given a bolus dose of 150. I usually wait a little bit, check the blood pressure, my pressure's fine, and I'm going to give another intracoronary bolus dose. And then we take another picture and see whether it's done a good job for us or not. Certainly the pressure's looking a lot better. Okay, well that's looking better. You could see that the flow of the contrast into the artery had improved. The time it took to transit the artery and to exit the artery had also reduced. And that's a sign that we've relieved a little bit, at least, of that microvascular obstruction. And you can decide at this point whether or not to give further bolus doses of those drugs to try and get that completely perfect. But we're not far off TIMI3 flow in this situation. And so we'll end the case there. This looks like a successful case of primary PCI for inferior STEMI. We've had a number of good learning points here, looking at the collateralization of the distal vessel, about the use of aspiration catheters, and about overcoming problems with no reflow. Thanks very much.